This is Jamie Court in Sacramento. I'm president of Consumer Watchdog, and we're fortunate to be here with Dr. Stephen Loyd and Bob Pack. Bob is the proponent of Prop 46, and Dr. Loyd is a really remarkable man doctor who's one of the few in America, I think the only in America, who's really been very clear about his addiction and what it means to be addicted and be part of the medical profession. And before we bring up Bob and Dr. Loyd to talk a little bit about Prop 46, we are releasing some statistics today. Prop 46 does three things. One is it does random mandatory drug testing for physicians to make sure they're not abusing illegal substances. Two, we have a mandatory checking of the physicians of a database that keeps track of all prescription drugs in the state so that we make sure we're not giving drugs to addicts and then hurt people. And three, we create new legal deterrents to medical negligence by updating the 38-year-old cap on damages that hasn't been indexed for inflation in 38 years. Our opponents in the medical profession like to say this is somehow going to drive up costs. Well, we know that Prop 46 is going to save lives, but it's also going to save money. And today we're releasing an analysis that shows that Prop 46 is going to save the state hundreds of millions of dollars. The state, hundreds of millions of dollars. And the way Prop 46 saves the state hundreds of millions of dollars is by protecting against substance abuse. So to bring forward these numbers that we've provided, I'm going to ask Carmen Bulber, the Executive Director of Consumer Watchdog, to briefly present the analysis, which is also online right now at consumerwatchdog.org. So you can read this analysis at consumerwatchdog.org. Carmen.
Hi, I'm Carmen Bulber, Executive Director of Consumer Watchdog. I'll be brief because this is a very simple calculation. As Jamie said, Proposition 46 requires physicians to check the statewide prescription drug database called CURES before prescribing narcotics to a first-time patient. This is to catch people who are doctor shopping, reduce the number of patients who are essentially drug-seeking, not seeking medical care. There are several ways that reducing prescription drug abuse in California can save money across the board. We focus solely on the savings to the state of California. The primary source of those savings is savings to the Medi-Cal program by reducing the number of people who overdose and who seek prescription drugs. So statewide, or not statewide, but nationally, insurance companies estimate that doctor shoppers cost $15,000 a year. In California, of course, we haven't to date had a requirement that doctors check the database before prescribing. However, 3 other states in the past few years have begun requiring that doctors check the database before prescribing narcotics. In those states, they've had remarkable success in reducing the number of doctor shoppers and the number of overdoses. For example, in Tennessee, the state that Dr. Loyd is from, they reduced doctor shopping by 46% because of mandatory use. In Tennessee, or in Virginia and New York, they reduced doctor shoppers by 75%. It was 73% in Virginia. So we used that success in New York to calculate what the savings in California would be to Medi-Cal by reducing the number of unnecessary prescription drugs, by reducing the number of unnecessary prescriptions, by reducing the cost of medical care and overdoses connected to that prescription drug abuse. And we found that California, with Medi-Cal alone, could save almost $300 million a year by reducing doctor shoppers by 75%. Now, there are also other savings from reducing prescription drug abuse, including savings to the courts, savings to law enforcement, and savings to productivity in the state in general. And so the overall range of savings, looking at other states' experience with mandatory use of prescription drug databases, is up to $406 million every year that California alone, state and local governments, could save thanks to Prop 46.
Thanks, Carmen. I'm going to bring up, before we bring up Dr. Loyd, Bob Pack to just talk a little bit about his experiences that led him to Prop 46 and why these provisions requiring mandatory use of the prescription drug database is so pivotal to stopping overprescribing and substance abuse among patients.
Yeah, good afternoon. My name is Bob Pack, and I'm the proponent of Prop 46. And I've been a patient safety advocate in the state of California for the last 10 years, helping spearhead 7 Senate bills around prescription narcotics and public safety. 10 years ago, my wife took my 2 children for a walk in our hometown of Danville in the East Bay, and were run over, killing my 2 young children, my 10-year-old son Troy and my 7-year-old daughter Alana, and injuring my wife. And what I found out afterwards was that the woman who ran over my children had been prescribed large quantities of prescription narcotics without a need for them. She was a doctor shopper. She had been prescribed a lot of Vicodin, Flexerol, muscle relaxants, and other drugs by numerous doctors, all from a single HMO, who testified that they never verified an injury, they never shared a medical file, and they never talked to each other before prescribing all of this prescription narcotic drugs. And so I set out on a path to try to do something about it, working with the state legislature and the Attorney General's office. In 2009, we developed together, which I helped architect and drive the legislation for, a real-time electronic monitoring system known as CURES to give doctors and pharmacists real-time, instant access from their office of a patient's narcotic prescription history, so they know their medications that they've received in the past before prescribing more. And that will have a dramatic effect on doctors, on reducing doctor shopping in California. And as Carmen mentioned, not just about saving lives, although I believe fundamentally that's the issue. Reduce drugs in our schools, reduce it on our streets, save addiction, save lives, but saving California $400 million per year by reducing these narcotics from our the effect on our social services, such as policing crime and judicial and fire and rescue and Medi-Cal, that this will fundamentally save lives. It's needed. And we tried to get this through the legislature, but it was fought by our opponents, and the bill was killed in 2012 to make it mandatory for doctors to use this CURES electronic system. And so here we are today, moving this ballot measure forward, Prop 46, to require that. And fundamentally, the law to increase the cap on malpractice damages and negligence, which prevented my family from seeking court justice from the doctors who negligently prescribed, who recklessly prescribed, but yet I was not able to get accountability because of this cap on damages of $250,000, which it takes that much to get to court. And so I believe strongly in Prop 46 and what it will do for California to save money. Mostly it will save lives, and it will reduce malpractice and harming patients and reduce doctor shopping in California. Thank you. And with that, And with that, I'd like to introduce Dr. Stephen Loyd, who's a medical director of his hospital, a VA hospital, who's come out from Tennessee, and he's going to share his own experience with prescription narcotic abuse and the effects on the population.
So let me, before you start, maybe I'll put Dr. Loyd on the spot a little bit. Dr. Loyd, by the way, is the White House Office of Drug Policy Control Advocate Champion of 2014. He's working with the White House, and the one question that I have, and we've spent a couple of days together, I'd love, for you to hear more about his story, but also is why do you think the medical profession in California, the medical establishment in California, is opposed to Prop 46? And do you think the medical profession is actually going to benefit from this as opposed to the medical lobby?
Thanks, Bob.
in asking the question about why the medical profession would be opposed to Prop 46, I think the first thing would be probably the raising of the malpractice cap, and that's not within my purview of expertise, so I'll leave that one alone. The second reason would be for the mandatory drug testing of physicians, and I think for that one it's because we view addiction as a moral disease. Addiction is not a moral disease. Addiction is an organic disease of the brain. It's like high blood pressure. It's like diabetes, and I would ask that you think about it in those terms, and it is a silent disease. I can tell you that every morning during my active disease, and I was at nearing the bottom at the time that Bob was losing his family 10 years ago. And every morning I woke up and I would get up out of my bed and I'd walk into my bathroom and I would look at pictures of my children on my sink when I was getting ready for work every morning, and I would cry, knowing that I couldn't stop, and I would throw a handful of pills in my mouth and go off to work for another day, and I thought that I would die in my sleep. I thought that's how my life would end. And the shame of telling someone that I had addicted disease, I couldn't do it. And that's the way my life was day after day, and I had a disease, and I looked at it as a moral failure. And so long as we look at it as a moral failure, that's what we'll be destined for. So I think that doctors look at it as a moral failure. It is not. And I think that drug testing will allow us to uncover it as a disease as it is, and will allow us to bring doctors out of the shadow who are suffering from addiction, allow us to treat them, and put them back into the profession where they are not endangering the lives of others. This is a patient safety position, like an airline pilot, like a bus driver. And, I teach my students all the time, when I'm on the airplane coming out to the Bay Area, it says if we lose cabin pressure, put the oxygen on yourself before you put it on the person next to you. That's because if you can't breathe, you can't do the person next to you any good. I teach my students that in the doctor-patient relationship in the room, who's the most important person in that relationship? And the students and the residents always go, well, it's the patient. No, it's not. It's the doctor, because the patient doesn't stand a chance if I'm not healthy. And I would say that the medical profession needs to approach it that way. That in order for me to do the patient any good, I have to be healthy myself. And for us to do any good as a profession, we have to identify those of us that have addictive disease. And the easiest way to do that is with mandatory drug screening. So don't look at it as an opportunity or don't look at it as a punishment. Look at it as an opportunity to us to reach out to those that we know are suffering. We know that there is a 2% point prevalence. You have 100,000 doctors in the state of California, and I don't know how many you do have. But 2% of them are addicted to substances right now as you speak. Whether or not you want to admit it, that's the truth. I would say that we reach out to them because they are putting others in harm as a result of their addiction. There's anywhere between a 10 to 18% lifetime prevalence of addictive disease. I say we reach out to them and help them, try to get them healthy so that they can help others instead of put them in harm's way. And then the last reason that would be objective to this, to Proposition 46, would be time spent to check the monitoring database. But I think it's a small amount of time. It is so easy to check. I think there's provisions that can be made to allow others to check the data bank for you in your office like we have in Tennessee. And if you look at the results, there's really no logical argument against not being able to query the database before writing a prescription for controlled substance. In the state of Tennessee, we've been able to decrease the number of doctor shoppers by 46%. Our number of prosecutions for doctor shoppers have gone up by over 120%. I had a question asked today. It says Proposition 46, saving lives. Where's the saving lives? If you look at prescription drug overdose deaths, accidental overdose deaths, in my state, Tennessee, they outnumber the number of deaths as a result of automobile deaths. Prescription drug overdoses, we have more of those than we do automobile deaths. Well, that is if we can cut down on the number of doctor shoppers, we can lower the number of overdose deaths for prescription narcotics. That's where the saving lives comes from. The saving lives comes from not having doctors that are impaired, causing damages to patients that would not be damaged otherwise. So the benefits greatly outweigh the risk, and I agree with Jamie and Carmen that the cost will be very minimal, and I think it will actually save money in the long run, and I think they have the statistics to back it up. And that's why I've flown across the country to support Proposition 46.
Do you you want to talk at all about how it's worked in Tennessee in terms of the mandatory check? Because Tennessee is one of 2 states, and a little bit about that.
Absolutely. The Prescription Safety Act of 2012 that was enacted required the doctors in the state of Tennessee to query the prescription monitoring data bank before writing a controlled substance for more than 7 days, and to query the data bank yearly for ongoing prescriptions. I can tell you that the results are nearly instantaneous. We're allowed to have someone from our office query the data bank for us, and the results to me have just been outstanding. And there's usually no gray area. It's not like that somebody is just on the borderline of doctor shopping. Usually it is very clear cut. The patient will be seeing, multiple doctors, going to multiple pharmacies. And the thing that I've noticed the most about it is that it doesn't match what my gut tells me. My gut tells me, oh, I need to watch out. This patient has a lot of red flags. And then I check the monitoring database, and it's clean as a whistle. And then other patients I look at and go, oh, there's a lot of red flags here. I need to really be careful with this one. And then, I check the monitoring database again. No issues whatsoever. Another patient I check, I'm not worried about at all. And then boom, 10 doctors, 12 pharmacies, 3 months. So what the monitoring database gives us is something that is objective. Okay, it's not shaded by anything else. It's not. It is not colored by any of the preconceived notions that I have. It is the single best tool that I have on a daily basis to combat the problem of prescription drug abuse, and it takes almost no time away from my face-to-face patient care.
I'm sorry, one more question, I promise. But since you're so rare to have a doctor to discuss this, can you talk a little about why your colleagues and maybe other colleagues might not, if they know it, if they knew a doctor was abusing a substance, how would they respond? And how did that work in your case with your colleagues? And how, as someone who was, as you said, intervened on, which your dad's here, maybe talk a little about how he did that. How did it feel when that happened to you?
When it comes to intervening on a doctor, it is really hard. We're one of the few professions that has been entrusted with monitoring ourselves, and we fail greatly in that responsibility. And the issue is, the problem is, it is so hard to do. We don't want to get involved. We don't want to hurt someone's reputation. We don't want to be responsible for them getting in trouble with their state medical boards. We don't want to be responsible for hurting their livelihood. The problem is that we as physicians impact a lot of other people. We impact families. We impact patients. And we have a great responsibility for patient care. So what my dad ran up against was basically the blue wall of physicians. He knew there was something wrong with his son. He could see a great change in me. He could see a great change in my physical appearance. Basically, I wasn't the same son that he used to know. It was the same thing that my colleagues saw. And why was it the same Steve that they used to know? I was rounding at odd hours. My behavior had changed. I wasn't up to date with my medical records. But nobody said anything. They didn't want to get involved. It weren't that they were bad people, just they had other things going on. And what if they said something to me and I reacted in a negative way? Or what if I wasn't using? What if they had made a mistake? And so they kept to themselves. And my dad had actually talked to several of them. He talked to my nursing staff. He talked to other staff around to try to get them to help me, and basically didn't get anywhere. So he confronted me on his own. And the day that he confronted me was, turned out to be the best day of my life. I thought it was the worst day of my life at the time, but it was the best day of my life. And when he did confront me, and I came clean with him, it literally felt like a drowning man in the middle of the ocean, and somebody come by and threw me a life ring. And I grabbed onto it, and that's when my life began to change. And I would ask the medical profession here in the state of California to look at it that way. As I speak right now to you, in the middle of the afternoon on a Monday, there are doctors across the state of California that are in their hospitals that are abusing drugs right now, that think their lives are over, that think that they're just going to try to get through another day, and that they don't have any idea how this is going to end. I'd like them to know that there is a way out and that there is help, and that their lives can only get better. But they can't get better as they are right now because they don't have anybody to tell, and they can only wind up hurting patients. I can tell you that it's been 10 years. I signed a lifetime contract 5 years ago, so I called this morning to see if I needed to be randomly drug screened. And the day I came out to the Bay Area this past Thursday, I found out that I got a promotion to the chief of medicine position at the hospital that I work at. So my life hadn't done anything but go up. Not only that, I'm a good option for my patients. I'm not impaired. I'm not using 100 pills a day. And I'm out here supporting a cause that I believe greatly in.
Thank you. Any questions we have for anyone, for Dr. Loyd or Plaza?
Dr. I'd like to ask you a couple questions about, are you okay with describing exactly how you evaluated what your addicted to was?
How much you use?
First notice issue.
You bet. Any questions, fair game. The person that first noticed was me. I remember the day that I went from taking 1 to 2. It got to the point that day that I went from taking 1 Lortab per day to 2. I looked myself dead in the mirror and knew I couldn't stop. And that was a horrible day. But the truth is I knew at that point that there wasn't any way out. And that was a day that I resigned myself that I would just keep going and see where I wound up. And it was a horrible day. I got started by taking a leftover medication from a dental procedure. And these are some of the things that we don't talk about enough. We talk about pill mills. We talk about doctors who are misprescribing in quantities. The truth of the matter is that 75% of all first-time users of opiate narcotics get them out of our medicine cabinets. Okay? The medicine cabinets that we all have in our homes, and they're leftover medications from a procedure. And so that's where mine started from. I had leftover medication from a dental procedure that I'd had months before, and it was at the end of a long day. So whereas you might come home from the end of a long day and maybe have a beer or a glass of wine or a mixed drink, I had some leftover Lortab. And I knew that my patients abused these drugs, and I thought, well, I wonder what it feels like to take one of these when you're not having any pain. So I snapped the Lortab in half and took it, and within 30 minutes, I felt like that I'd found alcohol that nobody could smell. I felt at ease. I felt like I had a nice energy level, and that's where it got started. And within 3.5 years, I was using about 500 milligrams of opiate narcotics daily.
You run across any other doctors in your profession who show those signs that you could identify? You intervene with other doctors?
Oh, a lot of them, yes, sir. I have, if you'd have told me that I was going to be doing what I'm doing right now when I was in medical school, I'd have thought you'd lost your mind. I've intervened on a lot of doctors in the previous 10 years. And it's interesting, the reaction that I get. Sometimes it's what you might expect. I have things said to me that probably don't bear repeating in this scenario or this situation. But most of the time it's the reaction that I had when my dad intervened on me. And it's a feeling of relief and tears. I cried for 2 weeks, I think, that somebody finally knew. And then when I figured out I could get better, now that was a huge relief. And I figured out or learned that I had a very treatable condition. Was an even bigger relief. And so as I intervene on doctors and they start to see the same things and they start to see that they don't have to live their life the way that they've been living it, it's the most fun I've ever had in medicine. The thing that I love the most about where I am right now is not having to chase pills every day. You think about whenever you get up to 25, 30, 40 pills a day, and you have to have that many every day, and the grind it is to come across them. Think about what that takes every single day. It's such a relief to not have to do that. And then I think about what good I can do with those experiences. And I get people ask me all the time, are you ashamed of that? Or do you wish you could do it over and not have to go through those things? And my answer is always the same. No. I'm glad that I had to go through those things because that's what I use to connect with people now. It's the experiences I use to connect with folks. It's the experiences I use to be involved with people like Bob Pack now and people like Jamie Court. That's why I'm out here now. I want the doctors in the state of California to realize what I'm talking about. The things in Proposition 46 are not to punish anybody. They're to make the patients of the state of California safer. They're to impact the impaired physicians of the state of California in a positive way to keep them from harming patients and to take them out of situations where they can cause patient harm and get them on the road to recovery themselves.
Dr. Wood, I guess people say to me, you know, hospitals and pharmacies, they account for all these things. Doctors can't get all these bills all like that.
That's a nice fairy tale land they're living in. That's simply not the case. There's a lot of things that have been created to prevent diversions, PICS systems, all kinds of accountability systems, and I can tell you that there's a way around every single one of them. At least there has been in my experience. If that's the case, I mean, how do you divert thousands and thousands of pills? I mean, I was able to divert a fair number of them myself, and there's just not a way to safely account for all of it. There's a hole in every waste system, I will guarantee you.
I mean, you were taking dozens, 100 pills a day. Where did they come from?
Absolutely. Well, the one thing that I wish that I could take back is that I used my friends. All of my friends are doctors. And it's just the nature of the beast. And I wish that I could take that part back, because these were folks who thought they were helping me. And they were not improperly prescribing. They were good folks. And I took advantage of my friends, and I do wish that I could take that back. But that was the bulk of my outsource.
Let me, if we can technologically do this, we'll try to open the phone line, see if anyone has a question. Does anyone on the phone line want to ask a question? Hello? Okay, well, if you do, you can reach us at 310-874-9989, and we can hook you up with Bob or Dr. Loyd, Carmen. Thanks all listening. Bye.